Welcome to Healthcare Processes and Decision Making. This is part five, the final part of this series. So, what does it really take for a single decision at the bedside to ripple across an entire healthcare system? In the earlier parts of this series, we looked at how clinicians gather data, reason through diagnostic possibilities, individualize management, and use structured tools like SOAP notes and decision analysis. In part five, we'll push further, examining how decision making extends beyond the individual clinician to include teams, systems, and technology. We'll explore how organizational imperatives, economic constraints, patient preferences, and health information systems all converge to shape real world decisions. This part is about connecting the dots, how individual reasoning fits within the larger ecosystem of care, and how technology, when well designed, helps align people, processes, and systems toward the common goal of safe, effective patient care. Let's go ahead and continue looking at the objectives for healthcare processes and decision making. So, we're going to discuss, again, just focus on a few here that relate to the topics we haven't discussed yet, and we're going to go into a little bit more detail in these. So, one of them that we're going to revisit is describe techniques or approaches used by clinicians to reach a diagnosis. And again, why this matters. Diagnostic reasoning is the foundation of care. Clinicians use systematic pathophysiologic heuristic mathematical approaches. We said all this before to interpret patient data and narrow down possibilities. And again, we mentioned how clinical engineers understanding how clinicians think about and use data clarifies why accuracy, usability, and reliability of medical devices are non negotiable. Engineers must design, maintain, integrate technologies in ways that support these reasoning strategies. For example, imaging systems that fit topographic approaches or lab analyzers. We've mentioned all this before. So, we're going to talk about keeping track of care. This final lecture looks at an essential but often overlooked part of healthcare, which is communicating the management plan to everyone who needs the information. The practice of keeping medical records goes back centuries. One of the earliest champions of this discipline was Sir William Osler, who famously advised his medical students never ask a new patient a question without notebook and pencil in hand. His point was simple but profound. Care isn't just about patient encounter in the moment, it's about creating a reliable record that can guide future care, support teaching, and ensure continuity. For today's clinicians, that notebook and pencil have become electronic health records, the decision support systems, and the digital communication tools. So, for clinical engineers, this highlights why information capture, integration, and storage are critical. A poorly calibrated monitor or a device that fails to interface with the EHR doesn't just create technical frustration, it creates gaps in the story of care. And when the story is incomplete, safe decision making becomes much harder. So, keeping track of care isn't just about writing things down, it's about building a record that guides, teaches, and protects patients across time, teams, and technologies. Let's go ahead and jump into building relationships and negotiating plans. A problem list is more than a checklist of diagnosis. It's a communication tool that helps clinicians and patients work together to prioritize care and negotiate realistic plans. Take this example: diabetes. So symptoms include polyuria, polydipsia, polyphagia, and hyperglycemia. This condition will require daily monitoring, education, and long term lifestyle support. Hypertension. Elevated blood pressure has been documented 3 times. EKG findings show left ventricular hypertrophy, meaning the heart is already showing signs of strain. Hyperlipidemia, these are big words. The lab values show LDL of 194, triglycerides of 250, well above recommended limits, and this increases cardiovascular risk and adds urgency to management. We can look at body mass index. Body mass index, let's say of 34, indicates obesity, which compounds all the other issues and must be addressed as part of the comprehensive plan. The problem list provides a structured foundation for discussion. It makes sure no issue is overlooked. It allows clinicians and patients to negotiate priorities, for example, whether to focus first on diet, blood pressure control, or weight management. It keeps the whole care team on the same page, ensuring continuity over time. For clinical engineers, problem lists highlight how data from devices and lab systems feed into care planning. Blood glucose meters, EKG machines, lipid analyzers, and BMI calculators all generate the objective data that appear on the list. Reliable technology ensures that the problem list is accurate because if the list is wrong, the plan that follows could put the patient at risk. Let's talk about who is the audience. When a management plan is documented, it's not just written for one person. It's meant to communicate with multiple audiences, each with different needs and perspectives. The patient's needs are clear, understandable, information about their condition and what they're expected to do. Family, friends, and the public may need reassurance, education, or guidance about caregiving. Clinical staff, such as nurses, therapists, pharmacists, dietitians, lab and imaging staff, they need precise instructions so they can safely implement the plan. Yourself, now and later, good documentation protects against forgetting why decisions were made, especially when you revisit the case months or years down the line. Colleagues rely on your records to coordinate care, especially during handoffs or in multidisciplinary teams. Beyond the immediate care team, there are broader audiences: consultants who provide second opinions, insurance companies who require documentation of approved coverage, lawyers on either side who may review the record in case litigation, compliance officers and regulators who audit records for safety and legal standards, researchers and data miners who aggregate records to identify trends to improve quality, performance measurement teams who access outcomes to track quality of care. The point here is that medical records must serve as multi purpose communication tools, teaching, guiding, defending, and measuring all at once. For clinical engineers, this reinforces why data quality, system interoperability, and information integrity are so important. Every time a device records a number, that data may eventually inform not just the patient's care, but also an insurance claim, a regulatory audit, or a research study. So the audience for documentation isn't just the patient, it's the entire health system, and every piece of technology engineers maintain contributes to that record. Communicating with patients. Communicating a management plan isn't just about giving orders. It's about building understanding, trust, and partnerships with the patient. Effective communication involves several key elements. Patient education. What's wrong? Patients need clear explanations of their diagnosis in plain language. If they don't understand the problem, they won't understand why the plan matters. Instructions. So, what to do? Clear, step by step instructions help patients follow the plan safely. This includes medications, lifestyle changes, and follow up appointments. Reassurance. So, what will happen? Patients often fear the unknown. Reassurance about what to expect reduces anxiety and builds confidence in the plan. Motivation and hope. Communication should inspire patients to engage in their care. Small wins and encouragement make long term change more likely. And acknowledgement and acceptance. So, listening to patient concerns, validating their feelings, and showing empathy strengthen that relationship. Commitment. I'll be there for you. Patients need to know they're not facing their condition alone. A message of support fosters trust and adherence. And for clinical engineers, this slide might seem less technical, but it's crucial. The tools and technologies you design or maintain, whether they are patient portals, EHR interfaces, home monitoring devices, or apps, are part of this communication. They need to be usable, reliable, and accessible so they don't become barriers between the clinician and the patient, but instead reinforce the clarity and reassurance that the patients need. Let's not forget communicating with family, friends, and the public. When it comes to communicating about a patient's condition, Family, friends, and even the broader public often want information, but sharing that information is not simple. It involves balancing needs, rights, and responsibilities. There are five key questions clinicians must ask. What do they need to know? So, a family may need practical updates. What's happening? What should they prepare for? What's their role in the patient's care? And what will be best for the patient? So, communication should always prioritize the patient's health, their well being, and their dignity. Sometimes what family members want to know may not align with what benefits the patient most. Next is what will be the best for family members. Families carry emotional and caregiving burdens. Sharing appropriate information can support their role, reduce anxiety, and prepare them for what's ahead. The next question is what can I legally tell? We have privacy laws such as HIPAA in the US. They strictly limit what can be shared without explicit patient consent. Clinicians must always respect these boundaries. Next question is what can I ethically tell? Beyond law, there are ethical considerations, balancing truth telling with compassion and respecting the patient's wishes, even if they differ from family's demands. And for clinical engineers, this may seem more like a clinician's concern, but it's highly relevant. The technology engineers support, like EHRs, patient portals, monitoring systems, are the very tools which this information flows through. Engineers help ensure that sensitive data is secure, that access is properly controlled, and the right people receive the right information at the right time. So, in other words, technology plays a central role in helping clinicians communicate legally, ethically, and effectively with families and the public. What about the clinical staff? When we think about patient care, it's easy to focus on the physician or primary provider. But in reality, safe and effective care is built on the contributions of a multidisciplinary clinical team. Nurses, they're often the first to notice changes in a patient's condition and are essential for day to day monitoring. They can monitor medication administration and patient support. We can talk about the pharmacists. They ensure safe and effective use of medications. They can check for interactions. They can check for dosage accuracy and patient specific adjustments. We have dietitians on that team. They provide nutritional guidance, which can be critical in conditions like diabetes, kidney disease, or heart failure. There are also therapists, from physical and occupational to respiratory and even acupuncture or massage therapy. These professionals focus on restoring function, improving quality of life, and supporting recovery. We can also look at the lab technicians as part of this team. They generate the lab results that drive diagnosis and treatment. They look at things like blood counts, or they get us the values for the blood counts, electrolytes, cultures, and more that the physicians need. And then the diagnostic imaging staff. So from X ray to CT and MRI, they provide visual evidence that clinicians need to confirm or rule out conditions. And for clinical engineers, this slide is a reminder that every one of these staff roles depends on technology. Nurses rely on things like infusion pumps and monitors. Pharmacists depend on medication dispensing systems. Lab techs depend on analyzers. Imaging staff depend on CT and MRI machines. And your role as an engineer is to ensure that all of these technologies work reliably, that they're all safe to use, and that they integrate into the broader health information system. When technology works, staff can do their jobs effectively. When it fails, patient safety is at risk. So the message here is supporting clinical staff with reliable technology isn't just about fixing machines. It's about empowering every member of the care team to deliver the best possible care. Let's talk about documentation and the self. So, clinical documentation isn't just about communicating with patients, colleagues, or regulators, it's also about communicating with yourself. Sherlock Holmes once remarked, nothing clears up a case so much as stating it to another person. The same principle applies in medicine. Writing things down forces clinicians to clarify their thinking. Processing affects the recording of a case. So when you record a case, you don't just capture information, you process it, which helps sharpen reasoning and highlights gaps. The effect of structure and order, well, organizing data in a structured way, like soap notes, brings clarity, patterns begin to emerge, and the story of the patient becomes easier to follow. If you look at the impact of recording technology, well, the tools we use, whether notebooks, dictation software, or EHRs, they shape how information is captured and how easily it can be retrieved later. Technology can enhance clarity, but if poorly designed, it can also introduce clutter or distraction. And let's not forget prospective memory, notes to oneself. Good documentation serves as a personal reminder what you thought at the time, why you chose a certain path, and what you plan to do next. Much like in the movie Memento, notes help preserve continuity when memory fades. So for clinical engineers, this slide connects directly to the design and reliability of recording systems. If technology interrupts the natural flow of reasoning, say by being too complex or error prone, it undermines the clinician's ability to think clearly. But when it works well, it enhances memory, strengthens reasoning, and supports better decision making over time. So, in many ways, documentation is as much about guiding the self as it is about guiding others. Okay, so how about communicating with other clinicians? So, clear, accurate communication isn't only for patients and families, it's also vital when working with colleagues and consultants. Colleagues, well, they carry future responsibility for the patient. So your notes and handoffs must be structured, detailed, and complete. The format and content of your documentation affect whether your colleague can quickly grasp the patient's history and next steps. As Evans noted in 1989, experts share knowledge not only of their domain, but of the structure and goals of their discourse. So, in other words, how we present information matters just as much as what we present. Let's jump into consultants. When seeking input from a specialist, it's critical to ask a clear question. The sharper the question, the better the answer. Clinicians must also decide what to share and what to leave out. Too much irrelevant detail can obscure the real issue. Different consultants, neurologists, psychiatrists, cardiologists, radiologists, each have unique needs for the information they receive. Tailoring the message ensures the consultation is effective. And for clinical engineers, this process is highly relevant. Every time lab results or imaging or device generated data flow through the EHR, they must be accessible, accurate, and properly formatted so that colleagues and consultants can interpret them without error. If an engineer ensures interoperability and clarity in how data are captured and displayed, they make it far easier for clinicians to communicate effectively with one another. So, whether it's colleagues sharing responsibility or consultants offering expertise, the quality of communication and the technology supporting it can make the difference between confusion and clarity in patient care. Let's talk about a real fun one here, communicating with insurance companies. I've done this for many years, so I used to do this for many years. So, again, another, and I guess back, let's get to being serious here. Another key audience for medical documentation is the insurance companies. Their focus is less on patient relationships and more on verifying what care was appropriate, what was necessary, and most of all, what was billable. There are several layers to this communication. So, documentation of the illness itself. We use ICD 10 codes. Insurers need clear, standardized descriptions of the patient's diagnosis. Without these codes, treatments won't be approved or reimbursed. We have documentation of the procedure. So, we have CPT codes, which are used to describe exactly what procedure or service was provided. Was it a blood test, an MRI, or a surgical intervention? Each has its own code for billing. We also have documentation of supplies, injections, and services. So the HCPCS codes are especially important for Medicare beneficiaries. They track everything from syringes to physical therapy sessions. Then we have the documentation of the processes. Systems like SNOMED, CT provide structured detail that links diagnosis and treatment plans, ensuring the record shows why a test or medication was justified. And for clinical engineers, this may seem far removed from technical work, but it's not. Much of this documentation is generated or transmitted by medical technology. Devices that record lab values, imaging systems that capture diagnostic results, and EHRs that transmit codes must all be accurate and interoperable. If a device misreports a value or if an integration fails and a code doesn't transmit, reimbursement may be denied. And more importantly, patient care may be delayed. So, communicating with insurers is not just about money, it's about ensuring that the technology backbone reliably supports the entire chain of care and accountability. So, the question is how much detail and in what form? When documenting in healthcare, one size doesn't fit all. Different audiences require different levels of detail, structured in different ways. So let's go ahead and break some of this down. Let's talk about the lawyers. The documentation is often used as evidence in court. Here, detail matters. Every note, timestamp, and justification may be scrutinized. Let's talk about regulatory agencies. So, agencies like CMS or FDA focus on compliance. They want records that clearly demonstrate adherence to laws, guidelines, and safety standards. Let's talk about the data miners, those doing data mining. So, for analytics and machine learning, structured and standardized data is essential. Free text notes may be valuable clinically, but are harder to extract and analyze. Let's look at clinical and outcomes research. So researchers require detailed, consistent, and accurate data, enough to track outcomes, compare interventions, and publish valid results. Next, we jump into quality and performance improvement. Hospitals and systems use documentation to identify where processes can be improved. Data must be structured and easy to aggregate, but also nuanced enough to highlight patterns of care. And let's jump into patient safety. Finally, at the heart of all documentation is safety. Documentation must be timely, accurate, and accessible to prevent errors, omissions, or miscommunications. So, for clinical engineers, this question how much detail and in what form is critical. You design and support the systems that capture, transmit, and store this data. If devices don't log the right details, or if the EHR systems can't display information in the right format, these audiences can't do their jobs, and patient care suffers. So, clinical engineers help determine not just whether data is recorded, but whether it's useful, accessible, and reliable for every stakeholder. All right, so let's go ahead and summarize what we discussed so far in this series. So, in this part, this lecture of this series, we've taken a step back to look at the big picture of healthcare processes and decision making. Remember, we first examined how clinicians gather patient data from symptoms and histories to lab values and imaging results. Then we explored how they analyze that data using structured techniques, heuristics, and mathematical reasoning to reach a diagnosis and formulate a management plan. And finally, we discussed how clinicians communicate that plan, not only to patients, but also to families, colleagues, don't forget the insurers, the regulators, and even researchers. Each audience requires a different level of detail in a different form. For clinical engineers, the key takeaway is this. Every step of that process, data gathering, analysis, and communication, depends on technology. From devices and diagnostic tools to EHRs and decision support systems, engineers, again, are the invisible backbone that makes accurate, reliable, and safe decision making possible. So, when we talk about healthcare processes and decision making, we're really talking about a partnership between people and technology. And your role as engineers is to make sure that partnership is strong, seamless, and trustworthy. Finalizing this unit summary is that we brought together the full journey of clinical decision making. We started by examining the role and nature of a clinician, how they operate within both classic and alternate paradigms of care. We looked at information gathering, processing, and analysis, showing how raw data becomes the foundation for insight. We explored diagnostic thinking and techniques, again, from heuristics and temporal patterns to mathematical approaches that guide reasoning. We reviewed models clinicians use to choose therapies and how they formulate a management plan, always balancing scientific evidence with patient context and system constraints. And finally, we looked at the communication of that plan with patients, families, colleagues, insurers, regulators, researchers, each requiring different levels of detail in different forms. And for clinical engineers, the takeaway is Every stage of this process depends on accurate, reliable, well integrated technology, whether it's data from devices, interoperability with EHRs, or the secure sharing of information across systems. Engineers ensure the tools clinicians rely on actually work and that they work safely. So the culture of healthcare isn't just about people or just about machines. It's about the partnership between clinicians and engineers to deliver care that is safe, effective, and trusted. And I want to thank you for your time and your consideration for the material presented today. The next series will be diving into nurse care processes. Just remember that as clinical engineers, your work shapes how knowledge flows, how decisions are made, and how care is delivered. That places you at the heart of medicine's most important mission, transforming data into healing. Thank you for your time.